This is David Magnus, Director of the Stanford Center for Biomedical Ethics, and I'm going to talk to you now about the ethics of the learning health system and of comparative effectiveness research. In general, when we think about research and research ethics and clinical trials, we usually tend to think of there as being a very, very sharp distinction between research on the one hand, which aims at generalizable knowledge, and systematic investigation. It's a systematic attempt to try and understand things about the world, versus treatment or therapy, which aims to benefit an individual and where there's a reasonable expectation of success. And in fact, that distinction is defined in our regulations in more or less that way. However, recently people have started to question the extent to which the research-treatment distinction can really be borne out in at least some areas of research that are very important. In a very important Hastings Center report by Nancy Cass, Ruth Faden, and colleagues, they point out that this sort of paradigm of this sharp distinction makes three additional assumptions about the difference: that research presents, in general, less benefit and more risk than clinical care, that research introduces risks from activities that differ from clinical management, and that research uses protocols that dictate what patient receives rather than individualized and best care. The problem is that that model may work well for some research, but not necessarily for all research. And in particular, comparative effectiveness research, which is referred to in different ways, quality improvement, quality assurance activities, the learning health system, point of care randomization, all of these challenge our notions of the assumptions. Generalizable knowledge is built into quality improvement as part of clinical care so that all practice for all patients becomes data for the improvement of how we treat patients. The systematic collection of data is now ubiquitous through the electronic medical record. There's also a lot of false views in the standard view about clinical care. Lots of clinical care is unproven, so QI is both research and benefits patients. Research doesn't necessarily introduce new risks in practice, especially when you're comparing two treatments that patients might have gotten anyway in comparative effectiveness research. And in practice, random exogenous factors may determine what patients get, not individualized wisdom. So if you go to one physician, you get one treatment. If you go next door to the doctor next door, you're going to get something different. We know there's a lot of practice variation that conforms to differences in geography, differences in training, differences in drug detailing patterns by drug reps. All of those things are factors in determining which of multiple proven treatments, or sometimes unproven treatments, physicians offer to their patients, rather than individualized wisdom about what's best for the particular patients. So challenges to comparative effectiveness research: largely retrospective data used, but that may be flawed. It may give you some information. That's one approach to the learning health system. But one of the things that's really challenging to find the answer. So there's a lot of practice variation, and physicians want to know what's best. If they rely entirely on retrospective data, that may not really give them a definitive answer. If they do prospective randomized trials, that can be hard to enroll patients. Documentation of informed consent may make it practically impossible, and oversight may slow the pace. And one example of some of the challenges of this was in the Provost famous checklist study. They added checklists about proper catheter placement to see if it would reduce infections, and they did this at 103 hospitals. It had a huge impact and showed dramatically reduced infection rates and led to really important changes in clinical practice, even though all that was being done was adding checklists for things that were standard practice. They had not gotten IRB approval from all 103 institutions, and the Office of Human Research Protection initially came down on investigators and called for a ban on data collection. The outrage over this did lead them to take this back. More recently, there was a controversy over a study called SUPPORT. The SUPPORT trial was looking at the way in which infants who are severely premature are treated for their lack of oxygen, it's known that if you don't give them oxygen, they will die. But if you give them too much oxygen, it was believed that it produced something called retinopathy of prematurity, or ROP, and would lead to increased rates of blindness. And over decades, data accumulated practices, and basically as information that was largely retrospective came in, there was wide swings in practice between higher and lower oxygen saturation targets. And then there was some data that was not randomized but was controlled data that led from Britain that led many leaders in the field to believe that you could reduce rates of ROP without increasing mortality or neurodamage by targeting slightly lower oxygen saturation target levels. In practice, different NICUs had different target saturation levels, some targeted at the low end of the range, some at the middle, some at the high. Many allowed a broader range. The guidelines called for anywhere between 85 and 95%. A survey revealed the practice range between 82 and 100%, with most tilting towards most but not all tilting toward the high end. But if you went to Tufts, you would have gotten 88 to 92. If you'd gone to the Children's Hospital in Houston, you'd have gotten 85 to 90. If you'd gone to Packard, you'd have gotten 85 to 95. So a lot of variation. There was some evidence that standard approach in premature infants might be less effective than continuous positive airway protection, which led them to make this support to be a 2x2 study. The hypothesis was that lower oxygen saturation targets would lower ROP without increasing mortality. There were international calls for studies to answer this question, and large efforts which included support but also the Canadian Oxygen Trial, or COT, which is 25 institutions in Canada, US, Argentina, Finland, Israel, and Germany. The BOOST study, which included institutions in Australia, New Zealand, the UK, and of course the support trial of 23 institutions in the US. So support is the surfactant positive airway pressure and pulse oximetry trial. It took place between 2005 and 2009, sponsored by NICHD. It took place among infants who were 24 to 28 weeks old. It was, as I said, a 2x2 study of CPAP versus conventional intubation, and whether or not shooting for oxygen saturation targets between 85 and 89%, that is the low end of the acceptable range, and 91 to 95%, or the high end of the acceptable range, would actually make a difference. And 23 different IRBs all approved this study. What they found was that at higher oxygen, there was in fact significantly higher retinopathy of prematurity. But they also, surprisingly for the investigators, that there was in fact a higher death rate slightly in the lower oxygen group. You can see almost 20% versus 16.2% with a p-value of 0.04. The COT trial did not find a statistically significant difference between the two arms in terms of death, but the BOOST trial did. As a result of that, the community concluded that there, in fact, is a slightly higher mortality rate for the lower oxygen saturation target levels. It's worth noting that non-enrolled patients at participating institution were also kept track of and had higher rates of ROP and death than either arm of the study. There was a consent process. Published papers on that consent process required 1.8 to 2.6 hours of discussion with researchers. On the whole, partly because of those informed consent requirements, the infants enrolled tended to be better. The children of better educated parents, and hence had more prenatal care. Concerns were expressed about bias in the sample as a result of that, and some suggested that it would have been better to have a waiver of consent to have a more representative population. The lead institution at University of Alabama, Birmingham, this is some of the language from the consent form. The babies in the study will be placed randomly, like a flip of a coin, into a group monitored with low oxygen saturation rates or higher saturation rates. And it explains all of that. And it says sometimes higher ranges are used and sometimes lower ranges are used. All of them are acceptable ranges. In this part of the study, we would like to pinpoint the exact range that should be used to prevent some of the problems that occur with premature babies, such as retinopathy of prematurity. The consent forms go on to say, because all the treatments proposed in the study are standard of care, there's no predictable increase in risk for your baby. Some unknown risk may be learned during the study. And at another place in the description of the purpose of the trial, it was suggested that lower oxygen may reduce ROP, and that was stated in 2 places. After these were published, there were tremendous criticisms by a group called Public Citizen and by the Office of Human Research Protection after an investigation that they conducted. OHRP denied there were any problems with the research design. However, they found serious deficiencies in informed consent, and in particular, that the investigators failed to disclose reasonably foreseeable risk. They claim that randomization introduced risks in this, and that being on a protocol rather than clinical judgment introduced risks. That's probably false, because all ranges were within standard of care, and therefore the research was minimal risk. But that became a subject of a great deal of fighting. There was a big pushback by the research community. The New England Journal of Medicine editors published an editorial criticizing the Office of Human Research Protection. So did the investigator, and so did a group of bioethicists. Art Kaplan and I published a perspective in New England Journal of Medicine that accompanied the editorial by New England Journal, arguing that they had made a serious mistake. And then in a follow-up, Ben Wilfond at Seattle Children's Hospital and I led a group of 46 research ethicists and a few pediatricians in saying that the OHRP was overreaching, and that we acknowledge that the permission forms could have been improved. We disagree. Random assignment of infants pose additional risks that the investigators failed to disclose. Another group of ethicists published a paper responding and saying that they thought that there were, in fact, seriously deficient failures to disclose risks, and therefore the determination of the OHRP was justified and did not overreach. So in the end, because of all this controversy, the finding was suspended by the OHRP, and the investigators did not have to do anything, and it remains the case right now. OHRP was going to produce some guidance on this topic. There was a lot of hearings held, but the guidance document that they produced was equally controversial, and right now this is a gray area in research. And part of this has to do with how we think about risk. Risk is the product of the anticipated probability of a harm and its severity or magnitude. But that's only one way of looking at risk. There is an alternative. That is to reject risk as a purely quantitative concept. And this is from Skip Nelson from the FDA. The fact that risk occurs outside of the research setting, whether in daily life or routine risk examination, does not make the same risk morally acceptable in the research context. And he explicitly rejects the idea of thinking about risk in the way that I and others do, as simply the product of the probability of a harm and its magnitude. I believe that it's important to distinguish between the known risks of available clinical interventions that you're trying to compare, the risks of the arms of a study, and the risks of research, i.e. the risks of being randomized on a protocol within the standard of care. In assessing the level of risk of a study is the latter that is relevant, that is, the difference between the risk of being in the study versus not being in the study. But this view is controversial. Risks must be reasonable in relation to benefits, and in evaluating benefits, the IRB should consider only those risks and benefits that may result from the research, as distinguished from the research and benefits of therapy subjects would receive even if not participating in the research. That suggests to some of us that this same standard of risk should apply to the regulations that cover the importance of disclosure of all relevant risks. However, it has not been clear whether or not OHRP interprets those later sections discussing risks in light of this claim about risks. Informed consent requires a description of any reasonable foreseeable risks or discomforts to the subject. Are those just the risks and benefits that result from the research as distinguished from those they would have received if they had been in clinical care? Or does it mean risk of any intervention that are described in the protocol, regardless of whether they would be exposed to those risks, even if not enrolled in the research? And here the real question is, to what extent does given practice variation, does it matter whether a patient is arbitrarily going to choose between one of two options, versus them being assigned one of two options on the basis of randomization? Is there a difference in risk if their treatment care is determined by randomization in a protocol versus it being arbitrary in the absence of evidence about which of two commonly utilized interventions take place? And that's really the core dispute. There's a growing group of us working on empirical studies of patient attitudes in this area. What we've discovered is that many, and arguably most, patients are willing to reduce the burdens of the consent process if it allows research to take place. So, for example, going from written consent to verbal consent, or even to just general notification that such research is going to take place. We've also seen hugely different views between IRB members and patients in terms of how they view consent. Patients actually don't distinguish very much and don't care that much about the distinction between randomization versus research that's observational using medical records. In addition, other groups have found that patients care much more about knowing what determines the clinical care choices that they get in cases where there's practice variation than they do about whether or not they've been randomized in research. So where do we go from here? One of the primary roles of informed consent is to demonstrate respect for persons. Our findings reveal discrepancies between the views of IRB members and patients regarding comparative effectiveness research, which we call research on medical practice, or ROMP. Policy deliberations among IRBs, researchers, and the public can help develop an approach that both respects participants and achieves research goals to improve healthcare. In an editorial that John Lantos published in Annals of Internal Medicine that accompanied an empirical paper that we published, he said, "It is time to ask whether a system in which the fundamental principle is respect for persons can continue to ignore the preferences of many of the persons it claims to respect." Saying this perhaps much better than I think any of us researchers could, a reporter named Kelly Benham, who had given birth to a 23-week-old after support had been concluded and had talked at length with her neonatologist about what it meant for the care, and this is what she had to say. "In the 196 days we sat by her bedside at All Children's Hospital, we signed consent forms allowing nurses to shove tubes down her throat and slip IVs into her thready veins. We consented to central lines that carry an overwhelming infection risk. We consented to test chest tubes, blood transfusions, and an operation so risky the surgeon fully expected it to kill her. Signing those forms was my first official act as her mother, and the responsibility made my cheeks hot. But I didn't read a single one. The only thing I remember about any of those forms was how it felt to write next to my name that I was her mom. All babies born so young are experiments. The rest is just paperwork."